Perfect. I was going to say, Kimber, let's get the recording started. So thank you. Um, Today we'll start with just a couple of introductions and announcements. Then we will pass it off to Dr. Chastain, who's going to be talking about um, hepatitis C and cirrhosis. And then we'll do, I think it's 2 cases today, and then open up for questions and answers and some closing remarks. But before we start with that, let's make sure that everybody is registered. We can go to the next slide. Sorry, Melissa. Let's make sure everyone is registered for continuing education that is interested through Southeast Age Education and Training Center. So you can scan the QR code or use the link that Kimber put in the chat to get registered. So we'll pause for just a second for registration. Making sure that you're registered through this platform as well also opens up a lot of additional resources and webinars and such for you to check out too. So I encourage you to register regardless of CE interest. And let us know if you've had any challenges with registration, and we can make sure to get you in touch with the right folks. So we'll pause for all right. So moving on while we're finishing registration with some in-chat introductions. Please, in the chat, share your name, your role, organization, and whether or not this is your first echo session. We would love to get to know you more. So please introduce yourself in the chat. I see some folks already putting in their information in there. Perfect. Welcome, everyone. And I'm looking in the chat. Awesome. I see our subject matter experts have introduced themselves. A couple people from TDH, it looks like, really excited to have you. And a few folks that mentioned that they will be. Oh, Bradley County. Welcome, Kimberly. I'm so excited to have you. I did hear that you'll be the second one in the Southeast region to be treating. So that's super exciting. Some other county health department folks. Love it. We're so excited to have you join. All right. Well, in the interest of time, we will go ahead and get it passed off to Dr. Chastain to talk more about hepatitis C and cirrhosis for today before we jump into those cases. So, Melissa, we can go ahead and get started, and I'll pass it to you, Dr. Chastain.
Great. And while I'm getting things squared away here, Melissa, if you can grant me remote control, I might be able to advance the slides on my own, if you have that option. And we'll see how this works. And if not, we will not do this in the future. And then the other thing I just have to say it looks like both to Kimberly as well as Jennifer. So I'm from Bradley County. So that's where I grew up. I grew up in near Cleveland, Tennessee, actually in McDonald, just outside of town, between Ooltewah and Cleveland. So my parents still live there and I love it. So for the rest of you, haven't met everyone on the call, although some are familiar names. I'm Cody Chastain. I am an infectious diseases physician and internal medicine physician at Vanderbilt University Medical Center. And so I'm our subject matter expert for adult HCV. Super excited to speak with you all and work with the TDH team. And a lot of you I've worked or collaborated with on individual trainings and others. Maybe we need to meet more, but I helped with Mia and her team as far as establishing, and we are growing our circle of experts. And that's the great thing about Project Echo is that as contributors and learners, You might be here to learn initially, but later you'll move forward. And as you move forward, you might actually be in a position to teach us and to share with us and also contribute as a whole, which is fantastic. Uh, with that all in mind, let me see if I can move it forward. Yeah, great. So disclosures, I don't have any disclosures other than I received funding from the Department of Health and Human Services under the Health Resources and Services Administration as part of the Ryan White program Part F, which funds the Southeast AIDS Education Training Center. And with that in mind, nothing that I'm sharing actually directly represents the opinions or views or official policies of Department of Health and Human Services, and that's in the grant info. Uh, yeah, so a couple other follow-ups. I think the reason some of you might recognize my name is that both my father and my grandfather were family physicians in the Cleveland, Tennessee area until they retired. Uh, all right, objectives. So at this end of the session, which goal is about 20 minutes, you should be able to define cirrhosis, identify signs and symptoms of advanced liver disease, contrast at least three methods of liver fibrosis staging, contrast compensated and decompensated cirrhosis. And this is where I think is probably the most uh, opportune for us to have a conversation is discuss how to differentiate decompensated cirrhosis from other conditions, other health conditions that can present similarly or have overlap. And I've got a case that I wrote to actually share and for us to discuss. So, first of all, I broke this down into questions. So, what is cirrhosis and what does it do? So, first object is to define it. This is simply severe fibrotic scar tissue in the liver. And you can see the surface of the liver in the top picture and a microscopic biopsy at the bottom. And you can see that blue stuff that is really scar tissue that is interwoven throughout the liver on the bottom. So severe fibrotic scar tissue, regardless of the cause, can decrease hepatic function, and that severe scar tissue can be associated with liver-related morbidity and mortality. When we think about adults, the most common reasons for people to develop cirrhosis today are metabolic dysfunction associated with steatotic liver disease. That's a mouthful. You might hear the acronym MASLD or MASH. Historically, you might be more familiar with NAFLD, non-alcoholic fatty liver disease, or NASH, non-alcoholic steatotic hepatitis. But those names really focus on the fact that they weren't alcohol related and really ignored the metabolic dysfunction aspects. So that's why there's a new acronym or a new name. The reason we're on this call is actually talk about viral hepatitis and support you all from treating and engaging clients and patients who have viral hepatitis. And that is a very common cause of cirrhosis. And then probably the third most common is actually alcohol associated liver disease. Dr. Lydia Alfaro Cruz could give us a great presentation, and we've shared this slide during prior presentations that for children, it's very, very different. Biliary atresia, genetic and metabolic causes, autoimmune hepatitis are reasons for cirrhosis in children much more commonly. Viral hepatitis can, but it's a very, very different active player. So while we want to treat kids and adolescents who have viral hepatitis, the likelihood you're going to run into cirrhosis in a child is a much, much different thing. So in adults, if you have hepatitis C causing inflammation in the liver because of the interaction of the virus and our immune system long enough, some people will develop cirrhosis. It's been estimated based on different studies that approximately 20 to 30% of people with hepatitis C for at least 20 to 30 years will develop cirrhosis. Very different story with kids. A study that Dr. Alfaro Cruz shared previously is that in patients with chronic hepatitis C, usually vertically transmitted from mother to child, is that over about 10 years, the vast majority of children do not have cirrhosis. That does not mean we don't want to treat kids. It doesn't mean it's not important to treat kids, but I would say that the likelihood that you're going to find advanced liver scar tissue in a child is much, much less. Now, if you have a vertically transmitted infection and that individual goes all the way to adulthood without treatment, that risk does increase. And so, again, identifying children with hepatitis C and treating it becomes a very important factor, but the likelihood that you would treat a child who has cirrhosis, less likely. When we talk about cirrhosis, it's scar tissue. Scar tissue, I've got scar tissue on my hands, we've got scar tissues over here. Scar tissue in and of itself doesn't cause problems, but it can often be asymptomatic. But once you have enough scar tissue in the liver that prevents the liver from doing its job, filtering the blood, allowing blood return through the portal system, filtering other toxins, then you can run into problems. So advanced liver disease can be associated with throwing up blood, swelling of the abdomen, which we often call ascites, or swelling in the legs that we call edema, confusion because of toxin buildup, which we call hepatic encephalopathy, or shortness of breath. And that's often because of fluid overload that can either be inside the lung cavity or outside the lung cavity. Those are symptoms that people might respond to if you take a history or see someone in the an urgent care or in the emergency department. But things that you can look for to actually identify cirrhosis. First of all, many patients might not have anything identifiable. You can't always just look at somebody and know they've got cirrhosis. They've got scar tissue in their liver. Doesn't mean that they've got symptoms. Doesn't mean there might be other manifestations. But you sometimes can see evidence of liver dysfunction, and that might be jaundice, ascites, redness of the palms or palmar erythema, spider angiomata, which can be spider veins, typically over the top of the chest wall or elsewhere, breast enlargement, whether it be in women or men, or encephalopathy confusion. So if cirrhosis is essentially scar tissue that puts you at risk for liver dysfunction, how do we diagnose cirrhosis? And so this is really important because liver fibrosis assessment can be done through liver biopsy, can be done through biomarkers, or it can be done through measuring the stiffness of tissue through different mechanisms. Liver biopsy, elastography, blood tests, a lot of them anchor back to this scale. This is a pathology scale. So pathologists who take a chunk of tissue and look at it under a microscope will grade the amount of scar tissue in the liver across 5 different levels, 0 through 4. 0 being no scar tissue, 1 being just a little bit of scar tissue around the portal triad within the liver, uh, more scar tissue that have lines, or scar tissue that goes and connects different chunks of the liver called bridging fibrosis. But once you get it throughout the liver and on the surface of the liver, we call that cirrhosis. So when patients say, "Oh my goodness, I've got stage 4 scar tissue," or "I have stage 4 cirrhosis," all cirrhosis is stage 4 fibrosis. It just means that that's the amount of scar tissues present. Liver biopsy is the historical gold standard. Taking a chunk of tissue is great because it tells you exactly what's there. But results can be impacted by the quality of the biopsy specimen. There are risks and complications. It can be limited in access. But I'll say liver biopsy still has a role in many areas of liver medicine or hepatology, but it doesn't typically get used for assessment of scar tissue for a viral hepatitis as often because we have other tools. You still might benefit from having a liver biopsy if your hepatologist is worried about autoimmune disease or another condition, but less likely that we would offer a liver biopsy today for the purposes of just assessing scar tissue. That's because we can measure indirectly. One way is to do a simple calculation called an AST to platelet ratio index. That's using an AST lab and a platelet count lab. And when it's really high, it can be highly specific for cirrhosis, meaning that if it's negative, you've ruled it out. But on the flip side, if this test is not very sensitive, and that's a problem because these tests can often miss patients with cirrhosis. But it's cheap, it's easy, it's usually related to labs we've already gotten. There's another laboratory study called the FIB4 index, or rather calculation, that can include age, ALT, AST, and platelet count. 2 of those are used in the APRI index, but age and ALT can add additional value. When it's really, really low, really helpful. A 90% negative predictive value if you get a number less than 1.45. If it's above 3.25, there's actually a pretty good chance that that person has advanced scar tissue. Doesn't guarantee it, but definitely increases the likelihood. In between 1.5 and 3.25, not nearly as useful. There's also a proprietary test called FiberSure that uses multiple known laboratory inputs and uses a proprietary equation. They don't give you the equation, don't know exactly what it is, but those numbers have been validated against biopsies in studies. And so generally speaking, we say this number on the FiberSure generally equates to this result on a biopsy. I'll be honest, in clinical practice, I'm not confident it's that much better than using APRI or FIB4, but some insurances utilize this as a way for approval. And so it's something good to know about. In modern medicine, one of the favorite ways of measuring scar tissues with elastography, which is the measure of speed of sound, and how stiff the liver is directly correlates with how much scar tissue is present. What you see in that picture is a version of transient elastography, but there's versions based on ultrasound. There's also versions based on MRI. And this is a great alternative to biopsy if your only question is how stiff is the liver. That is accessible in a variety of different radiology, GI, and or health department settings. Not always available, but it's a great tool if it's available to you in your setting. I do want to highlight what's not helpful for or routinely recommended for scar tissue or cirrhosis assessment. Getting an ultrasound, a CT, or MRI, there might be good reasons to get it, but you shouldn't order it just to assess for scar tissue because they're very insensitive. Uh, you'll catch less than 50% of cases of cirrhosis using these studies. The flip side, though, is if you see nodular contour or other fibrotic changes on these images, they're highly specific, meaning if you see it, it's there. But if you don't see it, it doesn't completely help you. These are the appropriate studies, however, if you're screening for liver cancer. So there's a lot of good reasons to get it in people with viral hepatitis, but I would say we shouldn't be using it as our predominant strategy for figuring out if someone has cirrhosis or not. We often refer to the simplified guidance in our talks about selecting therapy and choosing therapy. And so I want to highlight what does the simplified guidance say about assessing people for cirrhosis? It's this: liver biopsy is not required. We presume people have cirrhosis if they have a FIB4 score over 3.25 or any of the following: transient elastography that's abnormal, non-invasive serologic tests like FibroSure that indicate cirrhosis, clinical evidence of cirrhosis, imaging that shows nodularity, splenomegaly, a platelet count less than 150,000, or if you happen to have a liver biopsy available to you. So our approach is if you don't have any of these, that person can be treated as if they don't have cirrhosis. But if you do have any of them, even one of them, we generally recommend treating them for hepatitis C as if they have cirrhosis. And that means that you might follow or monitor that patient for liver cancer. You might follow or monitor or treat that patient with a treatment selection as if they had cirrhosis. Now, everything I've talked about in the last 12 minutes or so has all been stuff that we've covered before. But really, the clinical question that comes up is like, well, what's the difference between a person with regular old cirrhosis or compensated, meaning that their scar tissue in their liver still allows their liver to be doing its job, or decompensated cirrhosis when the liver is failing? How do we clinically assess that? What tools do we use? And how do we figure this out clinically in settings where we have really complex patients? Well, a reminder is that decompensated cirrhosis is a spectrum of anything from a person with a liver that's dysfunctional based on what it's producing or not clearing on lab work, all the way to the classic person who has got yellow eyes, yellow skin, a swollen abdomen, and has overt evidence of liver failure. This can be associated with confusion or ascites. But again, if those are present, that means that person has liver failure. Compensated cirrhosis might just be scar tissue liver without those symptoms. Patients who have liver failure often have elevated bilirubin, low albumin, and an elevated clotting time or prothrombin time on their lab work. And my pet peeve, I'll share, it's really important for us to think about our calculators that we use should only predict outcomes in patients with cirrhosis. If you use calculators like the Child-Pugh score or the MELD score on patients who don't even have cirrhosis, they don't add any value because they're only useful in patients who have known cirrhosis. So I think what we have to fix our mind is we have to evaluate all our patients, see if they've got cirrhosis. And once you know have cirrhosis, then you can depend on how bad is the cirrhosis. The two calculators that we often talk about in these says are the Child-Pugh score, which if you look to the right, has 5 different things, 3 lab markers, and 2 clinical assessments. And if you don't have anything bad, you're going to be class A. That's going to be a compensated cirrhotic patient. If you have any of the bad things, either symptoms or abnormal lab values, you add up the number of points and you're classified as class B or class C. Both class B and class C are decompensated cirrhosis. But it's really, really important to highlight that if you use this calculator and you use it on somebody who does not have cirrhosis, it doesn't add value. And I recognize that when you submit a case to our Project Echo, you submit the labs, you select the things, and then you put in the data, and it automatically produces Child-Pugh Q scores or MELD scores. But again, I would honestly tell you, we should just skip over those slides if we don't have any evidence that the person has cirrhosis, because they're only relevant if they do. A MELD score is another marker that uses age, bilirubin, sodium, INR, and creatinine. And this is used for organ allocation. This basically can grade the severity of liver failure and actually help determine how likely is the person going to die in the next 3 months. And that helps with allocation of organ transplants. And you can see the mortality associations from an online calculator there over 3 months based on some of those point totals. But really want to highlight if you have a person admitted for heart failure and you use a MELD score, but they've got completely normal liver, the MELD score has no bearing on anything. So patients who have hepatitis C who do not have uh, cirrhosis, we shouldn't be using these scores. A PELD score can also be used, and this is a tool that's used for organ allocation for children who have liver disease. And you can see that there are a few more pieces of data like weight and height that are also integrated. Now, hepatitis C treatment and liver failure is a really complex topic. I'm not going to get into this fully in details today, but one thing we can say is that if you treat someone's hepatitis C and they have liver failure, their MELD score will get better. But there's been a lot of uncertainty about whether you actually saved anybody's life. Liver transplant is the best treatment for patients who have Class B or Class C Child-Pugh liver failure. And the decision to treat hepatitis C pre or after transplant, or if they're not eligible for a transplant, should be done in conjunction with a liver transplant center when possible. That's from the guidelines. So if I have a patient who has decompensated cirrhosis, symptomatic cirrhosis with lab abnormalities and other physical exam abnormalities, what I'll tell you is that those patients should be seen at a liver transplant center if they can be to make a coordinated decision. That does not mean that you should not present patients here who have decompensated cirrhosis. I've treated patients over the phone with health department providers in East Tennessee and rural West Tennessee and other places, because sometimes that's the best of what that person could get. So I'm telling you that in guidelines, if you have a person with liver failure, if they were my family member, I want them to be assessed at a liver transplant center who had the capacity to assess them for that option. I'm really excited to share this study. This study has actually been published online. It's not in print yet, from the Journal of Hepatology. And this is actually a study about the prognostic implications of patients who achieve cure from hepatitis C who have either liver failure or if they improve. So this is a really complicated figure, but this is their graphical abstract. So let me walk you through this. There were 900 patients treated across several different centers, I believe in Spain, that had hepatitis C and cirrhosis. About two-thirds of them were men. The median age was 57. And most of them were compensated, but not all. About 700 of them had compensated cirrhosis. Had fibrosis of their liver, but they did not have symptoms and they did not have lab abnormalities. About 216 of them had ascites and had uh, confusion or had laboratory abnormalities. All of these people were treated and were cured of hepatitis C. Interestingly, about two-thirds of the people with decompensated disease got what they call recompensated. Their symptoms got better, their labs got better. They did not receive a liver transplant or other intervention. And then they followed these patients over time and how many people died and how many people developed liver cancer and how many people had other liver related events. And what you can see, generally speaking, those in the compensated row, the patients who had never developed liver failure, did the best. They had the lowest mortality rate, they had the lowest liver cancer rate, they had the lowest liver related events. You can see that decompensated cirrhotic patients had the highest rates, 50% mortality during the cohort, 12% rate of liver cancer, and a very high rate of liver related events. But what's really interesting about this is that after cure, about two-thirds of patients recompensated. And those patients, while they still had a much higher mortality and liver cancer rate than patients who had never gotten to liver failure, they did better from a mortality standpoint than patients who were never treated. I think this is some of the best data that we've actually had that says if you can't have a liver transplant and you have liver failure, treatment of hepatitis C is associated with decreased mortality, but it's not as good as never getting there in the first place or having a liver transplant as another option. So I think this is really important to so that we do have limitations of what we can do from a hepatitis C standpoint once somebody has liver failure. But up to this point, I think it's been really hard for me to say out loud that treatment of hepatitis C ultimately changed anything. And this study, I think, actually shows that it does improve mortality rates. It's just that it doesn't improve the mortality rates as much as we wish it did. So this really gets at the crux of it. This is the clinical question that we get sometimes at this group and others. Well, how do you differentiate between decompensated cirrhosis and other medical conditions with similar presentations? So let me give you a case. And I wrote this case in conjunction with a artificial intelligence large language model called Open Evidence. So I asked it to generate a case, I revised the case, generate the case, revise the case, and I think it's actually a pretty good reflection of what we might encounter in clinical practice. 54-year-old man presents with abdominal swelling and lower extremity edema over the past month. He reports fatigue and dyspnea on exertion. He has a history of hypertension or high blood pressure, high cholesterol, systolic heart failure, diabetes type 2, chronic kidney disease stage 3, and hepatitis C. On examination, he's got distended abdomen. He has swelling up to his knees that with pitting edema. He has mild jaundice in his eyes. And when you bring out your great old cardiology physical exam tricks, you look for a jugular venous pressure elevation, and you don't see any elevation. A prior echocardiogram shows an ejection fraction of 45 to 50%, which is how much the heart squeezes. Usually 50 to 60% is normal. Laboratory studies show mildly elevated AST and ALT, an elevated bilirubin at 4.2, an albumin of 3.2, a creatinine of 1.6, which is abnormal. Usually 1.0, 1.1 is the upper limit of normal, and an INR that's normal. His urinalysis shows trace proteinuria, which can be associated with chronic kidney disease, and his ultrasound abdomen shows mild ascites. So I would love for folks to either put in the chat or to come off mute and just tell me what are some things that you see in this case that make you think, oh, well, that's associated with the kidney. Oh, that's associated with the heart. Or, oh, I think this is related to the liver. Feel free to come off mute and suggest things or to drop in the chat and say, well, I think this is because of that, or this is because with this. Yes, Kimberly. Perfect segue. This was the case again. Um, what are the things that you think are related to Hep C? What are the things you think are related to liver? What are the things you think are related to the heart? What are the things you think are related to the kidney here? I saw Bill come off mute.
I was going to give somebody else a chance, but to me, it's really difficult to tease out whether the renal dysfunction is from the heart or from the Hep C. It's probably more likely from the heart, but the Hep C is definitely can be a contributing factor without in my opinion.
Yeah, Pepsi, it's a potential contributor. It's hard to separate out from the heart, which Bill, I think you're echoing the challenge here. Other folks want to pipe in about their experience, what things jump out to them about this case, or things that they want to drop in the chat. I will move no further until I get at least one response in the chat or one more comment.
You're being difficult today.
Oh no. Oh, I just love this.
Um, so given the fact that the ejection fraction is not absolutely terrible, I would not expect a lot of heart failure symptoms. The diabetes could be playing a role here in the renal function, and they could definitely have some venous insufficiency if they have the other risk factors related to diabetes.
I think it's a great comment. Yeah, it's like, the echo's abnormal, but not that abnormal. We also recognize that patients with diabetes, chronic kidney disease, and others can actually have chronic lower extremity swelling. And is that part of the puzzle or not? I think part of this case here is just really trying to echo this is This is actually really reflective of clinical practice when you're seeing a person with these type of symptoms. They're very rarely single diagnosis people. They often have multiple different contexts. So how do we separate this stuff out? And it's hard. There are a lot of different causes of swelling. And I will say, generally speaking, causes of swelling in the body fall down to five different chunks. Liver, which is often related to portal hypertension or poor blood flow back through the liver in the setting of cirrhosis, or low albumin. Cardiac, which can be heart failure or restriction of the heart and pericarditis. Renal, which can be from chronic kidney disease or loss of protein in the urine from something we call nephrotic syndrome. GI, which is much more rare, but protein losing enteropathies within the GI tract can lead to low albumin levels. And the other is lymphatic localized obstruction, but they usually cause edema in one place, not generally all over the body. Discriminating features, though, and discriminating features are diagnostic features that align with decompensated cirrhosis, but don't align with these other things. One is the frequency of ascites is much more common in patients with liver disease than it is with kidney or heart. It's possible, but ascites disproportionately collects there because of the portal hypertension. So if you see a person with tons of lower extremity swelling and tiny little bit of belly swelling, probably more likely from another cause than the liver. Whereas if you see someone with lots of abdominal swelling and a little bit of leg swelling, much more likely geographically located to relate to liver. I love that Jennifer shared that, the abdominal swelling, the lower extremity edema, it's hard to separate those two out because bad heart failure can do that or the liver can do that. But the other physical stigmata of chronic liver disease usually are not accompanied by heart failure. So jaundice or scleral icterus, which Jennifer picked up on, palmar erythema, Spanier idiomata, or encephalopathy, things we talked about before. If you have those things are not clearly in any way associated with kidney disease, GI, intestinal disease, or heart disease. The other thing is that elevated bilirubin or coagulopathy and elevated INR are not typically present in cardiac or renal causes. The exceptions are if you're on medications that cause those problems, like you're on the blood thinner for heart failure or another condition, you can't really evaluate that. And if you have bad enough heart failure, you can get congestive hepatopathy. But again, that's in a person with really terrible heart failure, and it probably won't be subtle in that particular case. So my rules of thumb for decompensated cirrhosis is that, first of all, collect staging data up front whenever possible, because you get a chance up front to assess them, to figure out how to care for their hep C later, and also to interpret their clinical care later. So anytime you can get early data, do it. When you're trying to discriminate between liver and other potential causes, look for the additional signs more commonly associated with liver disease, which are those specific physical exam findings, elevated bilirubin or coagulopathy. The ascites or lower extremity edema, those are harder to interpret out or section out. So look for the other crossover and use those Child-Pugh Q and MELD scores only in patients with evidence of cirrhosis. The reality is patients are hard. They don't all read the textbook. There's realities in the world that we sometimes have a lot of complexity, and sometimes we do the best we can. And I'll generally say that if a patient can't access specialty evaluation and you're uncertain if they've got decompensated liver failure or if this is another complex patient, we can treat that patient as decompensated liver failure, particularly if they can't access a specialist. And that's probably the right thing to do regardless of their health issue. So I'll stop here for questions. I know I pushed up against time. Would love to answer questions that we've got here. Um, and then I'll pass it back to Mia after like 10 Zoom seconds.
So fun fact from Dorinda in the chat.
Oh, this is amazing. This is amazing. Reaching way back in the Wayback Machine here, Dorinda.
Yeah, the Wayback Machine. It took me a long time to figure out because it was way back.
We've got so much more to
But
talk
yeah,
about.
we had all of our general pre-meds together.
We have to have more conversations about this. It only took us like a year to figure this out, but
Exactly.
So lots of great information presented today. Really appreciated the case study that you shared, Dr. Chastain, as well. Anyone with questions or comments before we move on?
I love it. Old Melissa, I will hand it back to you. I'm sorry I had